Hello and welcome to this video taken from the 2022 HIV guidelines for Uganda. We're going to spend the next 20 to 30 minutes talking about community service delivery, integrated community service delivery. And I'll give a background to this. The Ministry of Health released National Community Health Strategy 2022, which you can see the cover there. And this document is aimed at increasing availability and access, equitable access to community services for all people, all age groups, regardless of religion, regardless of race, regardless of where they are. And we want to increase community coverage of community services, and strengthen bi-directional referrals between health facilities and the community services so that there is increased demand and utilization of community health services. All our patients, including us, come from the community. So what better way of reaching them than taking the services to the community? This community health strategy, National Community Health Strategy document, looks at community health system strengthening. It talks about health service delivery in the community health workforce, health information systems, supply chain, community health financing, and leadership and governance in the community. All these are pillars of community health system strengthening. Why do we implement this? Why is it important? The policy guidelines for HIV, the 2022 guidelines, which were released last year, are aimed at accelerating achievement of the 95-95-95 targets for HIV epidemic control by 2030. 95% of people living with HIV should know their status. In other words, they should have been tested so that they know their status, they know they are living with HIV. And then 95% of those who know their status should be on ARVs, and 95% of those on ARVs should achieve virus suppression, which is the overall goal of treatment. So this integrated community service delivery model can help us to contribute or accelerate achievement towards these targets by helping in addressing determinants of new infections, for HIV prevention. It can help us to reach people in the community for testing them so they know their status. It can also help us with addressing barriers to virus suppression, which leads to advanced HIV diseases like TB, cancers. So through this integrated community service delivery, we're able to coordinate efforts or consolidate efforts for HIV case finding, get people tested in the community using index testing, which means we start with already existing HIV patients and we test their partners, we test their children. We also can strengthen patient literacy and psychosocial support, including providing directly observed treatment support services where we supervise treatment for patients who are not achieving virus suppression. We can address socioeconomic challenges which contribute to poor adherence at household level. We can link households to socio-economic service providers. And we can integrate other services like diabetes, malaria control in this integrated model. So integration means putting everything under one roof and using that opportunity to provide a complete package of services. So this model, what does it look like in a nutshell? We have to ask ourselves, when we're looking at the integrated service delivery model, we ask ourselves, what services are we going to provide? And where shall they be provided? When shall they be provided? And who will provide them? So we can analyze at facility level, we look at our data, and the services provided in the community will be the minimum healthcare package. For people living with HIV, we shall provide HIV testing services of family members, treatment literacy, which means health education, and making people understand what is HIV, how is it transmitted, how can it be prevented. Then we can also provide DOTS, directly observed treatment support, for those who are not yet achieving virus suppression. Maybe somebody is struggling to take the ARVs, they need supervision when they are taking them. We shall provide HIV prevention services, other services like safe circumcision, provision of PrEP and PEP, and also link households to socio-economic services, link them to community lending groups, circles, link them to parish development model, which we shall talk about in the subsequent slides. Then where shall these services be provided? In the community, anywhere in the community, at the household, at a health facility, at the parish, at the village health office, at a marketplace, taxi park, organized places, churches, mosques, children's orphanages, and so forth. So these services can be provided anywhere in the community, and we have to report on the services provided. Then who will provide them? Health workers from the facility, but also community health workers. The range of community health workers are many. We have parasocial workers, VHTs, village health teams, linkage facilitators, men, um, male champions, peer mothers, YAPs, expert patients, um, all these, retention facilitators, case managers, all these at community level, community health extension workers, all these are community health workers, and they're the ones who can provide these services. If we empower them through knowledge, we train them so that they are agents out there in the community providing these services. And then when can these services be provided? Anytime. They are flexible, but we recommend that each patient, each person living with HIV should have at least 2 to 4 clinical encounters with a health worker at the facility per year. And then we have to provide DOTS. DOTS for those patients who have not achieved viral suppression. It's provided daily. And then regular screening and referral for social services, regular screening for TB and other services. So it is recommended that each community health worker can manage 5 to 10 households. And this approach, as I mentioned, is targeting those most vulnerable individuals in the community. And we want to provide person-centered care, meaning that we package our services according to the needs of that patient, according to the needs of that client. And we want to be efficient. We want to maximize the opportunity when a health worker is at the household. And through this, we can break the chain of transmission. We can address mortality, improve adherence, enhance viral suppression, and we can also strengthen linkage to social services and support linkage to economic livelihood opportunities for the households of our patients. So this just shows that one health worker, community health worker, serves 5 to 10 households. And I listed the community health workers, whether they are peer mothers, parasocial workers, linkage facilitators, YAPs, expert patients, male champions, and so forth. We have a wide array of community lay workers. So at community level, the service package can include some of the things I've already mentioned. We can have a service package at the household level and a service package in outreaches. At household level, we can assess the root causes of poor adherence. Why is the patient not suppressing the virus? We can provide treatment literacy. We can test other household members for HIV, provide HIV testing services, HTS. We can provide supervised treatment, which is directly observed treatment and support for patients who are not achieving viral suppression. Patient-led TB screening and contact tracing, where the TB patient, for example, is the one initiating screening for symptoms among their household members, and they're empowered to do that. And even the community health worker works with that patient, works with that household to make sure that members are screened for TB and contacts are traced and investigated if they have symptoms. And then economic support, we can have linkages of this household to economic support services, linkage of the household to village VSLA, which is Village Savings and Loan Associations, linkage of this household to other service providers who can help address barriers to adherence, address barriers to non-suppression. Addressing barriers to achievement of viral suppression. And then screening and referral for other diseases like diabetes and non-communicable diseases, hypertension, screening for TB can be integrated at household level. Then in outreaches or what we call safe space meetings or group meetings where we meet members from the community in groups. We can link them to socioeconomic services. These savings groups like VSLA can be linked even to PDM, which is Parish Development Model, a government-led program. We can have integrated services like provision of ARVs. We can provide HIV testing, immunization, bleeding for viral load, EID, early infant diagnosis, sample collection, identification of HIV-exposed infants, mobilization of men for HIV prevention services for circumcision, screening for non-communicable diseases. So it's a big service package which can be provided to the groups that meet regularly. And we can leverage on community drug distribution points, these outreaches that we routinely do to provide ARVs. We can integrate other services. Then DOTS, as I mentioned, for those patients who are not achieving viral suppression, health education for treatment literacy, referrals and linkages to other services. So this community engagement framework looks like this. This is a conceptual framework, meaning that if we are to summarize everything that I've talked about, it entails mapping. We can begin as a health facility by mapping all the community stakeholders that we can work with. We can work with civil society organizations, teachers in the education sector, faith-based organizations, faith communities, NGOs, community-based organizations. We can work with the police, we can work with the legal systems, we can work with the agriculture sector, we can work with the security, the transportation sector, every sector. So we map them out and we identify who can we work with and who can we refer people to and who can refer people to us. Then once we've identified the stakeholders, and these also include the community lay workers that we are going to work with, those community lay workers, we train them on the community curriculum, which is more or less linked to what I am going through in this video. And then we can develop a referral map. What does this mean? That we know if where these service providers are located in the community, what are their contacts? If I want to send somebody there, who do I call? And this will involve also reaching out to them physically. You might have a police contact, you have a contact for a legal firm, you have a contact for a circle, the PDM focal persons contact you have. So you have this referral directory and a referral map for your catchment area and link the people living with HIV to these support services. And then coordination can be supported. We can hold meetings with relevant stakeholders, engage them, talk to them, get their contacts, find out how they will report to you completed referrals. And that is all done in coordination with the district community development office. The district CDO, community development officer, should work with the health officer, the DHO's office. So the community development office and the health office work together at district level to have that stronger coordination. And we want to use these frameworks to strengthen services for people living with HIV, including children and adolescents living with HIV in the district, with the intended outcomes of enhancing integration of facility, community linkages and referrals, strengthening CSO networks and their service provision in HIV and TB, increasing client access to quality TB, HIV, and other complementary services, improved adoption of priority behaviors at individual, household, and community levels, and improved data visibility for use in programmatic decision making and planning. So what are the thematic areas? We look at client-centered service delivery, robust M&E, reporting and monitoring, evaluating the processes involved, treatment literacy at all levels, coordination and collaboration at all levels, all targeting the people living with HIV in the community and the communities at large. So when we talk about bidirectional facility to community referrals, this diagram is showing us that collaboration, or that coordination, that link between the health facility and the different actors in the community that I already talked about. And what are the roles of the health worker in this? The health worker will help with mapping, because you're at the health facility. So map out the community structures that are within the catchment of the facility, the health facility, that we can work with. Develop a service provider directory, establish collaborations for facility community linkages and referrals. Then select the structures depending on the gaps that those structures can help you address. For example, if it's an OVC, you have an OVC, you need to have that strong linkage with the OVC service organization. If there's a gap in adolescents, find out adolescent groups in the community or NGOs that work with adolescents. If it's something to do with economic support, is there another project, another partner who is dealing with economics at household level that you can work with? Then the community structures should be coordinated at the health facility by a focal person. So at our facility, we should have a focal person for community coordination. And then we have regular meetings, joint support supervision to address bottlenecks in this collaboration. What are these gaps or the bottlenecks I'm talking about? The current picture in terms of facility to community linkages and referrals, we have challenges with coordination. The delivery of services is not well coordinated at community level. We have so many types of community health workers visiting the same home every day. For example, I might have today someone's home, someone living with HIV. You have a VHT come in the morning to deliver ARVs. He goes away. 2 hours later, a mentor mother comes to check on the pregnant mother in the same home. She goes away. 3 hours later, a YAP, youth and adolescent peer, comes to the household for HIV testing. The youth and adolescent peer goes away. Then after the following day, the TB team comes for TB contact tracing. So you've had all these people making multiple visits to the same home, which is inefficient. There's duplication, and there's also increased cost that you have 4 trips. Yet if you just had one community health worker coming to that same home, and this community health worker has been trained on the service package to provide, they can provide all those services in one setting. It is efficient, it saves time, it minimizes missed opportunities, but also the person who is being visited is not overwhelmed. Imagine every time they have to prepare tea for this visitor. They have every time, there's stigma. Someone is knocking at the door every time, coming for a different service. And because of these fragmented services, we've become inefficient. The service delivery is not well coordinated. It's expensive, time wasting, and an inconvenience also to the person who is being visited at home. So the service delivery is fragmented. It is in silos. There are no agreed upon models and approaches. And as I mentioned, there are many missed opportunities that we have multiple visits, yet one efficient visit that is comprehensive, integrated, would cover a lot of ground at that home. So we are missing so many opportunities in diagnosing those on treatment. We have missed opportunities in supporting those who are interrupting treatment not to interrupt. Suboptimal viral load suppression is not being well addressed. And then the information systems in the community are also poor. Poor documentation, capturing of the data from the community is poor, and this affects decision making, planning, and we're not able to account for the money that we are paying to these lay workers, for example. And then the human resource at community level is not trained. Their capacity is low in managing HIV and TB, in providing treatment literacy, in screening, in, referrals. And then there's a lot of duplication, and the community health workers also, we're not optimizing them to achieve the 95-95. Yet they are a big workforce and a big opportunity if we tap them properly. How do we do this now? I'm going into the last segment of this video. How do we operationalize the integrated community service delivery approach? We start by health education and orientation. Who do we educate? We educate the clients. We educate the community health workers, even fellow health workers like I am doing now. And then we talk about this community model. We talk about the fact that HIV services, TB services, malaria, hypertension, diabetes can be provided in the community, not only at the facility, but we can reach them where they are. And we create awareness about this model. And among the tools we can use is this treatment literacy handbook. This is a desk job aid that you can use when providing treatment literacy, which means you're providing health education to somebody about HIV, how it is transmitted, how it can be prevented, why they should take their ARVs every day, and so forth. Then after health education, we go on to map. Remember, we talked about mapping community service providers. We're also going to map non-suppressed patients. So for starters, we're starting with the non-suppressed patients because these are the priority at this point. They are the ones who are not yet achieving our desired treatment goal. So we are going to map the non-suppressed clients. Where do they come from? Which villages do they come from? Which sub-counties? All our non-suppressed from the non-suppressed register. And as we speak, we know that we have different cutoffs. Above 200 for plasma, 400 for DBS. And then we want, first, let's prioritize patients with high-level viremia, the non-suppressed patients. And then we continue with the multi-month dispensing, 3 months, based on their eligibility for multi-month dispensing. But we know where they come from. We know the sub-county, we know the village. And then after mapping the patients who have non-suppressed virus, we now go on again to map the community health workers. Where do they come from? Which is their parish? Which is their sub-county? And once we've mapped them, we train them on the service package. So we're going to have training for lay workers so that each lay worker is now equipped with knowledge that when they visit a home, they're able to provide a comprehensive integrated service. Then the next step after training the health workers is to attach them to the clients. Attachment of community health workers to the clients means a meeting with the clients so that the clients know their community health workers who are in their area, who will be coming to their homes. And it's recommended that for the patients who are non-suppressed, 1 community health worker is attached to 5 non-suppressed clients, being mindful of distance, being mindful of capacity of that community health worker. And the reason we are keeping it at 5 is because there's a lot involved. There's dots, there's home visits every day, so we need to be mindful of that. And then once we've done the attachment, the next thing is for the community health worker to conduct the home visits at household level. They use the 5 A's to assess, assist, advise, agree, and arrange, trying to find out what are the causes of this non-suppression. Why is this patient not suppressing the virus? What is affecting the adherence? Using the 5 A's assessment strategy, which is integrated into their tools when they go to the home. They have the tools they use, and these tools integrate. They have these 5 A's in there for assessment and trying to find out the causes, and then agreeing on next steps to support the client. Then once that the household visit also includes DOTS, non-suppressed patients should be provided daily DOTS for at least 30 days. And then HIV screening and testing of eligible family members, providing treatment literacy, health education, linking to socioeconomic services, PDM, VSLA, TB screening, contact tracing. So all these are done within the household home visit. After 30 days of DOTS, the community health worker will continue with weekly visits until the patient is bled for viral load again. Hopefully, the patient will suppress. But this community health worker has to report to the focal person for community services at the health facility. And they use what we call the community client encounter form, the report, which I will show you at the end of the video. So let's talk about DOTS, which is directly observed treatment and support. It means that a community worker or other designated individual watches the patient swallowing the dose of prescribed ARVs every day, supervised swallowing. And it's recommended that all non-suppressing patients put on DOTS support by the community health worker every day for the first month so that we are sure. It's important to ensure compliance with treatment and decrease the number of patients interrupting treatment. It is done at home. It can be done in the community, maybe at a shopping center, at a shop, at a marketplace, but every day. So the health worker and the patient agree on where it will be done. Mutually agreed place and time. And why do we do it? I mentioned to help us achieve viral suppression and rule out adherence challenges. So the last step is what we call safe space outreaches, safe space or integrated outreaches. This means meeting people in the community in groups. A safe space is a point where people living with HIV and their family members come and access integrated clinical and social services on a quarterly basis. These safe space outreaches are held quarterly. And in those outreaches, you provide a number of services, ART provision, HIV testing, immunization, socioeconomic services, linkages to VSLA, PDM, parish development model, and so forth. And before we do this safe space outreach, the community health worker communicates to the health facility when they are organizing that outreach to meet groups. And this also has to be communicated to the district office, community district officer, communicate to the PDM supervisors about the planned date for this quarterly safe space outreach. And then the health worker uses the service gap audit tool. It's a tool to list what will be needed. It's a planning tool. What shall we need in this outreach? What medicines, which patients are coming, and what will they need? Then we pack the required items for that outreach, and then the health worker at the community health worker mobilizes the people who will come for that outreach, and the outreach is held on the agreed date at the agreed location. And when we are doing this outreach, as a health worker for you from the health facility, you can provide health education. The community health worker can also give health talks. The CDO from the district, remember we informed him or her, they register the clients who have come. The other health workers provide services like testing, immunization, identification of HIV-exposed infants for early infant diagnosis, EID, screening for NCDs, refills for ART. Then we have to document and update this information for the HIV patients. in the EMR, that's Electronic Medical Record System, and we also have to document in the registers, and this is in preparation for the report. And then the PDM focal person can give information about socioeconomic opportunities, maybe form the PDM group that will benefit from the government program. And we should also integrate the OVC, service provider, conduct case conferences in that safe space outreach, and also link clients to other services like dreams for the adolescents. So it's a comprehensive, integrated outreach. And case conferences basically mean discussing clients who are difficult, those with recurring problems, so that they can be addressed by different stakeholders. And these case conferences should be integrated into those safe space outreaches. So community health workers with particular cases which need to be discussed, those cases can be identified by the CDO or social worker, and they should also attend these case conferences, these outreaches, safe space outreaches, so that they are also discussed in that setting. So as I summarize, as I wrap it up, what is important in the aspects that we need to consider during operationalizing this integrated community service delivery: it is led by communities. It is voluntary, community-based. It targets rural areas which are very distant, over 5 kilometers away from the health facility. All people, regardless of anything, regardless of race, regardless of age, regardless of status, can attend these, are targeted also for these community services. The recipients of care or beneficiaries are reached in their community, whether at a school, a church, a public building, a marketplace. And the costs for these activities, all those activities that I've mentioned, might have a cost implication, which is catered for by the projects, by the donors, by the Ministry of Health, by the district primary PHC funds of the health facilities. Let us include all these activities when budgeting. What do we need? We need health workers, at least 2 to 4 minimum. We need medicines, we need supplies, we need means of transportation, the venue, we need the mobilization, we need the funds to cover costs, and we need to report what has been done. And when we are reporting, there's a reporting template here which captures the information from the non-suppressed patients who have been reached, how many were bled for viral load, how many had dots done, how many people in the household were tested for HIV, linked to socioeconomic services, had TB services provided, and other services like malaria, antenatal. And these indicators are disaggregated by age and sex, and also type. Pregnant and lactating mothers have their own column. So there is a dashboard for monitoring the implementation of the community service delivery model. It's at dsduganda.com. Visit it at any time, and it will show you the different data of non-suppressed patients mapped in different villages, linked to community workers. It's targeting high burden villages. And then the ministry, which is the leader of this program nationally, conducts bi-weekly performance review meetings with different implementing partners, and also conducts monthly supervisions. So this is the treatment literacy desk job aid, which I talked about, which you use to provide HIV patients, households with information about HIV, how it can be prevented, how it is transmitted. Also TB is included in there. Then this is the client encounter form, which the community health workers use when they are reporting their visit at the household level, and they use it to report to the community focal person at the health facility on progress being made in assessing the barriers affecting adherence for the non-suppressed patients. And it also guides them on which information to give. For example, advise the people at the household level You know, do they need treatment literacy sessions? Their family members requiring HIV testing. So this client encounter form is also guiding the community health worker on what to do within the home. So as I wrap it up, what are we going to do? What next? What are the next steps? So what we are requesting is that you map non-suppressed TLHIV by village at your facility. Map community service providers. Identify and train the community health workers from the sub-counties where there is the biggest burden of non-suppressed patients. Map the stakeholders, I've talked about that, the community service providers. Equip the community health workers with tools, equip them with client literacy equipment, equip them with client encounter forms, equip them with all these tools that they need. Then attach these community health workers to the patients with non-suppressed viral load, and then report on the work being done. I want to thank you so much for the last 36 minutes. It's been great, and I hope you've picked a thing or two from this presentation about the integrated community service delivery. Let's go out there and serve. Thank you.